off, and we've started the recording.
Okay. Give me just 1 second. I have a very squeaky chair here, so I'm having to substitute a different chair. I apologize. Okay, everybody hear me okay? Dr. Harrison? Okay. So yeah, this is a case presentation and discussion to follow. Our patient is a 7-year-old gentleman with a history of non-Hodgkin lymphoma, treated with chest radiotherapy as well as chemo over 20 years ago, who presented for a risk evaluation for coronary disease. He was initially seen in our clinic about a year ago. A few weeks prior to that, he had presented to a local ER with some left arm pain that sort of radiated to the chest, was sharp, awoke him from sleep. Earlier that day, as he routinely had been doing, he had taken a long walk, 5 miles. He did not eat breakfast that day, worked all day, and then went on to have a late lunch with clients. It was a very indulgent meal, as you can see, that was full of some fried foods and other fatty foods and good stuff. Went shopping at the mall, walked around after that, did fine. Understandably wasn't too hungry at dinner time, just had 2 glasses of wine. Went to bed at 9:30 p.m. And early the following morning, he awoke with chest pain and presented to the ER at 3 a.m. The pain did not subside for hours despite nitroglycerin. In the ER there, his EKG just showed left axis deviation, but no STT changes. His chest x-ray was unremarkable. He had a limited echo there that showed normal or low normal EF, moderate aortic regurg, and was otherwise unremarkable. His blood work showed that he did not have acute MI, at least by cardiac biomarkers. His other lab work was unremarkable, and of note, his white count of 26 and platelets on a little bit on the low side are related to another chronic illness, and we'll touch on that. He did have a exercise SPECT scan the following morning or later that day, I guess, and he exercised for 6 minutes, 30 seconds. His exercise capacity was 8 metabolic equivalents. He had appropriate increase in his heart rate, 89% of maximal predicted, didn't have chest pain or ST changes, nuclear images were normal, EF were normal. So on our initial visit, he didn't have any complaints. There was no additional chest discomfort or really perceived physical limitations at that point in time. His past medical history is significant for non-Hodgkin lymphoma. It was treated about 25 years prior with radiation to the chest and then pro-MACE MOP chemotherapy. This is a adriamycin or anthracycline containing regimen. And he also had the tumor subsequently resected post-therapy. He's followed yearly by the NIH. He does have now chronic lymphocytic leukemia, which is the cause of his laboratory abnormalities we touched on. This was diagnosed 5 years ago. It's felt to be stable, and there, does not warrant any any medical management at this point in time, and it's just being observed. He does have gastroesophageal reflux and diverticulosis. Importantly, a family history. His father had a fatal MI, about 4 years younger than the patient at the time of presentation, and his mother had coronary disease and died at an elderly age. He's a non-smoker. He does occasionally drink alcohol, about 5 drinks per week. His medications are shown here. The Librax is for his diverticulosis. Aspirin, low dose, was due to his age and strong family history, more as a primary preventative measure. And then some other over-the-counter type of things here. His Physical exam was relatively unremarkable. Blood pressure is normal. We did have a lipid panel that showed he does have dyslipidemia, total cholesterol around 250, LDL 170. He had not been treated with a statin up to that point. This was his EKG on initial presentation to our clinic, and presumably identical to what it looked like in the ER. He does have left axis deviation and poor R wave progression in precordial leads, and slight prolongation of the QRS, about 110 milliseconds, consistent with left anterior fascicular block. So this is, where we are right now in terms of guidelines for patients such as this patient that have a history of chest radiation exposure, and they either have symptoms suggestive of angina or they're asymptomatic and you're thinking of doing a screening test. This is a figure from some guidelines published about a year ago, and really is the only guidelines specific to this group of patients. And this was a sort of multi-society guideline, American Society of Echo and European Society of Cardiovascular Imaging. So what they recommend is that you get a good history and physical, obviously, and look for any signs of any of these conditions that can be secondary to radiation. In our particular case, we're worried about coronary disease, and our patient had some symptoms, although not really true angina, and now currently is asymptomatic, so we're sort of working both sides of the algorithm, but at any point, both sides sort of point towards a functional non-invasive stress test and echocardiography, which we had a limited echo in the ER, and we did have a stress test in the ER that was normal.
So, Greg, you
so
would
we found
say that
some risk factors as well.
Greg, you would say that you pretty much completed his workup then, correct?
Well, there are some other things we can do to further stratify risk. A carotid ultrasound, I think they put it here for more neurological workup, but I think from a standpoint of defining atherosclerotic risk, that can be helpful. And we subsequently, as I'll get to, went on to do that. And a full echo, a better echo than he had probably in the ER. I think that was just a limited study, so a comprehensive echo, and we went on to do that, and I'll get to that. But essentially, for coronary workup, yeah, we had completed the functional non-invasive test that is recommended if symptomatic, or at 5 to 10 years after exposure, which he's now about 25 years post-exposure. And in other patients, if they're presenting earlier, they say if it's high risk, you would go on to do this. But I think a patient that had non-Hodgkin lymphoma, where these guys get high-dose chest radiation plus a positive family history, that's probably puts them in a higher risk category. So I think, either way, you would have been able to justify doing the stress test based on these guidelines. So our echo and carotid IMT did confirm he has some aortic insufficiency, 2 to 3 plus, which is not surprising 25 years after chest radiation. Moderate MR. The rest of his exam was pretty normal. He had mild diastolic dysfunction, normal EF. Carotid showed some non-calcified and calcified plaques, but nothing hemodynamically significant. Of note, because he had a very sort of fatty meal before the onset of his symptoms, we wanted to make sure his gallbladder was normal, and ultrasound of the gallbladder was unremarkable as well. So now we have done everything on here at this point in time in terms of the workup for angina and coronary risk. Modifiable risk factors have been identified. We've done echo, we've done non-invasive, we've done carotid. But could we be missing something? And I think that the reason that we sort of were a little bit unsettled still was because of this strong family history. Knowing that the perfusion studies, the stress tests, don't always identify coronary disease, even in patients with significant functional coronary disease, significant stenoses, it's not 100%, but definitely in people that may be at high risk due to plaques that aren't flow limiting now but could be vulnerable. And, so we went on to do a coronary CT.
Hey, Greg?
Yes.
Would you like to ask the audience what they would recommend doing at this point before you go on?
Sure. We can ask if anybody would, if most people would just be happy with where we are, or if anybody else would feel compelled to do any further testing.
So this is Ann from Minnesota, and I think it's great we're having this conversation, because to me, when we see patients like this in our survivorship clinic, we sort of pause, what else do you do next? They make you uncomfortable, but I don't think we have a lot of good, I think it's great these guidelines are there, but it still makes everyone feel uncomfortable. I know at our institution, for patients that seem high risk, oftentimes we're doing MRI. I don't know if that's the right thing to do, but I think trying to basically to look in more detail. Does it change the management? I'm not actually sure that it does.
That's good.
Yeah,
And Joe Carver, what would you think? Any comments from Joe Carver? Any comments from anyone else? Thank you, Ann.
And to just reply to Ann's remark about MRI, I do think that stress MRI is probably more robust to detect three-vessel disease, and definitely if a patient has had a silent MI, we can pick that up. But in terms of identifying subclinical plaque, we can't do that with MRI currently. I do think, though, from if this patient had had his initial stress test in our clinic, it probably would have been a stress MRI instead of a nuclear. So we went on to do a CT, and we chose to look at the anatomy because of his risk of left main and proximal epicardial disease, given the chest radiation as well as the family history. It just seems like, a too high risk situation to be missing something. And this type of stress test he had was one that we, again, just don't have complete faith in. But then, you have to go into this thinking, what would be the significance of non-stenotic plaques in the coronaries? What's that going to change? We've already identified that he's got dyslipidemia, so we're going to treat him with a statin. He's already on an aspirin. So that's something just to keep in the back of your mind and, really to try to justify while you're ordering the test.
Is there anybody else?
And just to touch a little bit on plaque detection, coronary calcium scoring is widely done, and this is good for people in low to intermediate risk that are asymptomatic. It can sort of identify a high plaque burden, but it's not very plaque specific to say if there are any specific plaques that could be problematic. It's really more just for risk prediction. Coronary CTA, on the other hand, does reveal both calcified and non-calcified plaque, and it can demonstrate vulnerable characteristics. The very remodeled and highly lipid-filled plaques, and these, especially if you find these type of plaques proximally, it can carry some incremental prognostic value. Now, what do you do is still sort of up for debate, but I think at the very least you have a patient that you can counsel, to be on guard, and definitely not to ignore any potential symptoms. So this was our patient's CT.
Hello, Greg?
Yes.
Is there anyone else in the audience who would consider doing a coronary CTA?
I didn't hear any yeses or nos. I'll take that as a maybe. Should I go on? I'm going to proceed.
Okay, proceed.
This is our patient's. This is our patient's CT, and it's really, we're looking at it in sort of LAO and RAO, for lack of better terms, projection. So on the left here, this is the LAD on this left image. It's over to the left of the image, and so this is the left main and the LAD bifurcation, circumflex. But this view is really to look at the LAD and the left main, and we can see the left main. There's some diffuse disease. You can see some sort of non-calcified and likely sort of fibrotic plaque with maybe a little lipid in it here. But to say how bad is the stenosis of the left main is very difficult because we don't have a reference segment because it's sort of diffusely diseased. And then the LAD, we have some non-obstructive sort of calcified plaques. If we look over here on the right-sided image, this is where we have the circumflex kind of splayed out, and this area down here was an area of misregistration due to some diaphragmatic movement. So this is not plaque here. Up here, though, we can see the bifurcation, and again we have some narrowing, especially sort of proximally and distally in the left main. And then this is the circumflex. This is a continuation of LAD. It just goes out of the plane, so don't worry about that. We already saw it on the other image. But we can see that there is some plaque in the circumflex here proximally as well, and it does have, you can look at it on both images here. We see some calcium in it, and it's got some darker areas suggestive of some lipid, but really not flow limiting, maybe 40-50% stenosis at best. You could probably say 40 to 50% for the left main here too, although we do see these plaques in the distal left main that look like they could have some lipid in them and be potentially vulnerable plaque. But at this point in time, when asymptomatic and it does not appear to be any flow-limiting disease, there's not much else to do other than to tell him that he's at risk for events based on his coronary anatomy, and to be vigilant about symptoms as well as intensification of lifestyle medical therapy. So we started him on 80 milligrams of Lipitor, and I think that's something where this test kind of can. Oh, I've told somebody has their hand raised. Does anybody have a question?
Joe Carver has his hand raised, but he's self-muted.
Wolfie has a question. Is Dr. Carver there?
Dr. Carver has his hand raised, but he's self-muted.
So I'll ask a question. It's Ann. As we're talking, a lot of stuff has come up recently about fish oils, and I'm just curious about whether, many patients are willing to take quote-unquote fish oil as opposed to a prescribed medication, and whether or not you think that would be beneficial in this situation too.
I think, depending on the lipid profile, if they have, the HDL and triglyceride, if they're sort of on that end of sort of close to metabolic syndrome, I think, pathophysiologically it makes a lot of sense. For other people, I don't see a downside to it at all, other than that, they can be costly, and a lot of the over-the-counter types, it's sort of hard to know exactly what you're getting.
What you're getting, yeah.
Yeah, but I don't think it's something that I would ever tell a patient to stop if they were happy to take it and tolerating it. But I guess compel patients to spend that type of money for something that I don't know has a lot of data behind it. It's not something that I've been pushing. But I think it's something that can definitely be discussed in high-risk patients, and say that it could have potential benefit. I don't know if you feel differently, or if Dr. Harrison does, or anybody else.
Yeah, I don't have strong feelings about it. I raised the question because it's something we're asked about, regularly. I think the Lovaza with the higher doses of omega-3 people feel a little more comfortable with, but I'm not, it's certainly not something like global. I would agree with what you said. I mean, I don't tell people to stop it, but I'm not avidly prescribing it either.
Yeah, I think another therapy that could be considered, but there's definitely no data behind it. But if you think that a patient has high-risk coronary anatomy, but is not not obstructive, would be dual antiplatelets. That's something we've talked about when we've picked up patients
Right.
with sort of complex plaques, but we don't think they're not having angina really, that would warrant revascularization, but they've got really very remodeled and highly sort of lipid-laden plaques, and sometimes you can even see a sort of thin fibrous cap look to it, or the appearance that it has already had a little bit of sort of rupture, but sort of has been self-contained, but still not flow limiting. So those are patients that the dual antiplatelets would be considered, but that's definitely on a sort of per patient level, and the risk, they have to be very, very low risk for bleeding for you to consider that. And yeah, I think that the main thing that you can feel comfortable doing is you can say we have definitely identified a patient with atherosclerosis, with coronary disease, and that they should be on a high-intensity statin, and go down that path, versus just the sort of primary dyslipidemia kind of therapy. That we have identified a patient that has coronary disease and should be treated as such. So that's what we attempted to do. And we didn't start them right away on Lipitor, but we sort of pretty rapidly titrated them up. And this use was limited by myalgias, so we had to stop the Lipitor, and we started them on low-dose pravastatin, and ultimately titrated them up to 40 milligrams, and that's been well tolerated. So not ideal, but by guidelines, but having them on at least a good dose of pravastatin is better than nothing. And he was able, again, not extremely limited physically, so was able to exercise 5 miles, walking a couple times a week.
Greg, do you have that cross-sectional image of the color-coded plaque with the lipid content?
No, I wasn't going to get into all that today because there was so much else to talk about, especially as it relates to this, which was his acute presentation. This was 8 months after his initial presentation to our clinic. So he saw us in early September, so this was April of the following year. And this is when he was out of town in North Carolina. He had 4 hours of constant chest pain with shortness of breath and diaphoresis. And I think it took him a little while to get to the ER, and that's why he had 4 hours, because he definitely knew, if he had discomfort to go to the ER, but I think he was in a sort of remote area in North Carolina and had to get to the ER, and then was transferred to a tertiary hospital from a smaller hospital. So by the time he got to the main ER, the final destination, it had been 4 hours of chest pain. He presented with systolic blood pressures that were borderline 90s, and he was tachycardic with a heart rate to the 120s, but he rapidly deteriorated, systolic blood pressure dropping to 60, heart rates in the 30s to 40s. This was his EKG on initial presentation, although I don't have the one when he hit the door. They mentioned in his discharge summary that he had some inferior ST elevations, which I don't see here, but I do see these R waves that are prominent in the precordial leads. And if you remember, he had poor R wave progression initially. And he's got these ST depressions in the anterior leads as well that, if you look at this EKG upside down, you'd see Q waves and ST elevations suggesting a posterior MI. And if you'll recall his coronary anatomy, he had that large dominant circumflex that we saw. So this was his cath. At the time of cath, he actually had 2 cardiac arrests and was on maximum support. So a lot was going on when they did this cath. So if the images aren't ideal, we can certainly forgive the angiographer under the circumstances. But we can see this is a RAO view, and we see the LAD here going off to the right. It looks okay, and then we just see a little stump here in the proximal circumflex. The bifurcation looks okay. That was where we saw some plaque. But this area of this proximal circumflex is actually, if we flash back to the prior year, it's actually this plaque right here. It's got some calcium, some lipid, but definitely not a flow-limiting plaque. But it does have some high-risk features, mixed calcium, and positive remodeling and lipids. So they got a wire across it, opened it up with a stent. This is the post-angioplasty. You can see the osteal circ and the left main do have some disease. Here's the LAO view. Proximal left main, you know, they thought definitely was not normal, and they did do intravascular ultrasound on it on the way out, and they didn't call it more than 50%. They said 40 to 50% based on that. Again, no reference segment, so hard to say. This was the post PCI LV gram. You can see hypokinesis in the inferior wall here. They only did one view. The anterior wall looks fine. For what that's worth. And the EF, I think, is sort of artificially increased here because he was on pressors and inotropes at this point in time. So during this presentation, you know, we showed the STEMI and that they put a drug-eluting stent in. So he went into cardiogenic shock in the cath lab, PA arrest, and with one round of ACLS came back and then went into VFib, was shocked. We talked about the IVUS. They didn't think that it was significant, and they even said because he was on pressors and all this stuff that there could have been some spasm with their guiding catheter sort of tickling the left main and all the pressors that, you know, they were reassured. So in the cath lab, he was intubated on maximum vasoactive support and had a balloon pump placed. His hospitalization lasted about a week. He did have an echo pre-discharge. Luckily, he recovered within a week, you know, he felt safe for discharge. His EF was low at that point in time, 35%, and he was discharged on CoReg, ramipril, aldactone, in addition to aspirin and statin and dual antiplatelets. And this was his EKG around time of discharge, and you can see he has had resolution of his ST abnormalities, but still has these prominent R waves, consistent with MI posteriorly. So he came back to us pre-cardiac rehab about 6 weeks after his STEMI, and he was having a little bit of exertional fatigue, and we thought it could be his CoReg, which he was on a pretty good dose of. We changed that over to Toprol, and actually he felt better. We did go on to repeat a coronary CT, and the interventionalist at the time of his angioplasty had recommended some follow-up imaging of the left main, so that's why we went back and looked at that. And really, it looks the same. I think now it looks even worse if you look at the circumflex as a reference segment, because it's got that stent in it that sort of inflates the diameter of it a little bit more. But we can see the left main looks sort of diffusely diseased with this sort of really fibrotic sort of look to the plaque, and then we've got this distal left main and osteal circumflex plaque with calcium and it's really dark, which suggests some lipids. LAD still looks fine. This is the more of the RAO view here. You know, the stent's laid out. Everything looks good with the stent, but definitely this left main and bifurcation disease persists. But given you know, the very close and detailed evaluation of this plaque in the cath lab, we felt like we could monitor it, so we did. And we felt good about him going to cardiac rehab, and we knew if we had symptoms with increasing exercise that we'd have a reason for it. So he was tolerating cardiac rehab, so up to 3 months after his STEMI. He did have some fatigue. However, his baseline exercise tolerance was 6 METs, and this increased to 9 METs at 3 months into cardiac rehab, or rather 3 months post-STEMI. This is probably 2 months into cardiac rehab or so. Because he was discharged from the hospital with a low EF post-MI, and he had been on optimal medical therapy, we wanted to do repeat imaging of the heart to see if he had any indication for defibrillator and that type of thing. So we did do a cardiac MRI. Also, the MRI is nice because you can see if there's any viable myocardium left. If you're thinking revascularization may be indicated later on down the line. So we were sort of interested to see how big was this MI from a scar standpoint too. So this is his 2-chamber view on his MRI. I will say that his EF was measured quantitatively from the study to be 48%. And the anterior wall and apex look to be moving fine. The basal inferior wall is a little hypokinetic there. Same thing here on the 3-chamber view. Anterior septal wall's fine. Apex looks good. The posterior wall is a little hypokinetic. Here you can see that AI we talked about, but it wasn't more than moderate or so. This is the 4-chamber view. Things look real good there. This is the delayed gadolinium. So this is the view where we look for scar. And dark means healthy, and very bright, like brighter than the blood pool, means scar. And as we saw on this view, that he had good contractility in all segments in the 4-chamber. What we were sort of worried about was the posterior wall, which here looks totally viable on this. The anterior wall looks fine, apex looks fine, posterior wall totally viable. Also, the inferior wall is all viable. Looks just like the anterior wall and apex. So there's really no big scar. This suggests that, and here's the short axis views. This is the area, a dominant circumflex distribution. It all looks the same as the rest of the heart. So this was reassuring, the fact that he didn't have any scar at all. He'd had a pretty big MI, but was revascularized in a timely manner and didn't sustain any permanent damage based on this. However, we were a little perplexed as to why his EF was still low. And luckily, we do this is resting perfusion, but as part of the cardiac MRI protocol, he had resting perfusion sequences done, and you can see these areas of sort of subendocardial hypoperfusion. I think it looks a little bit worse in what would be a sort of dominant circumflex territory, and the LAD maybe doesn't look so bad, but this was something that we didn't have a stress perfusion image to compare it to, but definitely we felt to be suggestive that maybe there was some functional flow impairment based on his left main and circumflex disease. But he continued to do well in cardiac rehab in subsequent weeks, and then as he got from the about 9 METs level to about 10 METs, he started noticing some increasing actually tooth pain or jaw pain with exertion that improved with rest of about 5 minutes. And that same day that he noticed that, he came over to the clinic, and we considered this to be essentially typical angina. And given the left main stenosis and the distal left main and going into the circumflex, the wall motion abnormalities, without significant scar and the perfusion defect, we said, okay, well, everything all points to this needing to be fixed, given that a left main has prognostic significance, and that we've known for years people generally do better with revascularization of the left main. He had a heart cath done subsequently with a flow wire with FFR, and for people that may not be familiar, the FFR measures the gradient across a lesion, and anything less than 80% or 75% is considered abnormal. It's considered flow limiting. If there's a 75% decrease in flow across the lesion, more than 25% decrease in flow across the lesion. And in this case, his FFR was 0.63, so this was very significant across that left main. You could argue maybe this is the test that should have been done initially during his catheterization. But at this point, that sort of answers all questions as to whether this is a functionally significant lesion in the left main. His left internal mammary was angiographically normal, which is important because we know that the lima is the most important vessel for grafting, and probably all of the prognostic benefit of cabbage over stenting is due to the lima and the fact that it's a very durable graft. So a few days after his cath, he went on to have the first portion of a staged procedure to revascularize his coronaries, and we decided to go with a hybrid coronary revascularization. The first part of this is an endo-ACAB, and what that is an endoscopic atraumatic coronary artery bypass with lima to LAD, and then subsequently, once they protect the LAD with the IMA, they do PCI to the non-LAD vessels, which would be the left main into the circumflex in his case. And the reason we wanted to do this hybrid type of approach, the endo-ACAB, is illustrated here. So on the left here, the conventional open on-pump bypass is a large, basically the entire sternum is split and retracted. And in patients that have a history of chest wall radiation or mediastinal rather radiation, this can be very tricky. They're at risk for sternal wound infections. There can be adhesions. Pericardium adheres to the chest wall, and they can be at risk for a lot of problems related to sternotomy. And also these people, their recovery is just longer in general. So the way that the endoscopic bypass works and as part of a hybrid procedure is actually they do a mini thoracotomy just right around the apex where they're going to anastomose the IMA to the LAD, and the rest of the procedure is done with ports or trocars where they put these sort of robotic arms through, and they can do the rest of the procedure robotically. This is showing them suture robotically. This here is showing them actually dissect out the IMA robotically. So it's a relatively minimally invasive procedure where the only chest access is these three little ports and a mini thoracotomy. So in a patient with history of radiation to the chest and that type of thing, this can be theoretically beneficial. And we'll talk a little bit more about that. This here is actually his post-op angiogram, and they're panning down from the catheter up here in the subclavian. This is the IMA grafted to the LAD. Generally, when they do it this way, it's a little bit more of an apical, or distal LAD anastomosis, just based on the anatomy. But you can see a very good result. Anastomosis looks great here. The entire LAD is retrofilling. You can see competitive flow there. And then 2 days later, they went in for the angioplasty portion of the procedure. Is a catheter in the left main, a wire across the left main and ostial and proximal circumflex here. And you can see just with that wire in there that we're not getting very good contrast and pacification, which is suggestive that, you know, these lesions really were worse than initially thought. Here's a RAO view of the same thing there with the wire across. And this is the stent being deployed. And this is post the angioplasty. You can see the left main looks good, wide open into the circumflex. This is where that prior stent was there. So everything looks open here. You can see some competitive filling down there in the LAD. So fully revascularized without a sternotomy. We'll talk a little bit more about why we chose that, but a little bit later, you know, in the discussion portion here. But I thought that this case brought up some really good discussion points for patients that have a history of chest or mediastinal radiation and concern for coronary disease. So I'm just going to touch a little bit on the detection of vulnerable and stable type of coronary disease in these patients, and then the treatment of multivessel coronary disease. So this is a very relevant topic because we know that these people, and this is actually data from patients with breast cancer, I think, though, that it's relevant here because it's a large study and very illustrative of the risk that is directly proportional to the mean dose of radiation in terms of gray and the increased rate of coronary events. You can see a linear relationship there. And it's not just dose. Patients with increasing age and risk factors at different sort of levels of radiation are at increasing risk. And this is looking at death from ischemic heart disease. And here we're looking at least one subsequent coronary event after radiation. And you can see here, I think it's interesting, the patients with no cardiac risk factors that have had the highest level of chest radiation, and this is with a heart dose of 10 gray, are actually equal to patients that have had no radiotherapy but that have coronary risk factors. So that when you add to the high dose radiation that our patient had related to his lymphoma, plus the fact that he had risk factor with family history, I think we can see why he would be higher risk. So now we're back to this algorithm. So knowing that patients with radiation history, chest wall radiation, mediastinal radiation, are at risk, what does our algorithm say? If they're asymptomatic, 5 to 10 years out, you can screen with a functional non-invasive stress test. If they have an angina, basically it feeds you back into this functional non-invasive stress test. So what is the utility of that, and what is the data of functional non-invasive stress tests? Well, we'll start with looking at patients that could potentially have a vulnerable coronary disease. And there's really one study that was published now 15 years or so ago that sort of speaks to this and the value of non-invasive stress testing in these patients that have had mediastinal radiation. It was 144 patients. On average, they were imaged 14 years post-radiation, and this was a screening test. These were asymptomatic nuclear exercise testing. And 5 of these patients, which is 3% of the total cohort, had abnormal tests. 2 subsequently were revascularized. Interestingly, in the subsequent 6 months after testing, 3 patients that had a normal test had an MI, with 2 of them being fatal. So the same amount of people that had positive stress tests and went on to have revascularization, the same amount of people in the group with normal tests actually had fatal MIs. So that sort of illustrates that this test isn't perfect by any means, and especially when we're trying to identify patients with probably those vulnerable plaques that are more rupture prone versus the ones that are sort of more stable ischemia-producing plaques. So what about those functionally significant plaques, that you'd think would cause angina or that would be good for revascularization? This is the biggest study in patients with a history of radiation, and it was about 300 patients, but the catch is that only 40 of them went on to CAD. So in talking about positive and negative predictive values, the patient numbers are not very high. But we can see with stress echo, nuclear, and EKG that the false positive rate actually for stress echo isn't bad, so maybe that would be a good test. But false positive rate with nuclear was nearly 90%. That the specificity was only 11%. Stress EKG actually was very good in this group of patients. The false negative rate for stress echo, though, was pretty high, about 40%, and about the same for nuclear. So with nuclear, the overall sensitivity was 65%, but the specificity was 11%. So, I mean, that's just like not even as good as flipping a coin. Stress echo was a little bit better, but again, a false negative rate of 41% is not really ideal. And again, this was just 40 patients, and not specifically looking at patients with left main and three-vessel disease, which we don't have data on in this group of patients after mediastinal radiation. But if we look at the data that we do have from the largest studies and sort of the seminal studies on nuclear perfusion, we see that patients with three-vessel disease in these two studies, the sensitivity for thallium SPECT was 90% in one study. If you look over here, it was 80% in the other. So that means we still have a false negative rate of 10 to 20% in patients with three-vessel disease with nuclear techniques, maybe because of balanced ischemia or things like that. But again, this I don't think is an ideal test for these patients that are at risk for proximal disease, proximal multivessel disease, left main disease. I showed this. This was actually patients that have a history of radiotherapy in childhood for Hodgkin lymphoma that were followed up years later, but it showed nicely the location of the plaques in patients post-mediastinal radiotherapy, and the left main comprised about 15%. And when you add the proximal LAD, that was another 20. So over a third of these patients had what would be considered probably prognostically relevant locations, left main or proximal LAD. And when you look at the proximal circumflex and the proximal right, that got us up to about 2/3 of patients that had proximal disease or left main. And that's illustrated over here with their figure from their paper. So this was the one paper that has looked at coronary CT in terms of screening for patients with history of mediastinal radiotherapy. It was only 45 patients, so they sort of called it a pilot study. But they did have some interesting findings in their 45 patients. And this table here shows the 9 patients that actually had abnormal or pretty markedly abnormal CTAs. And of those, 5 or 6 of them actually had revascularizable disease, but I want to focus on these 2 that actually had significant left main. So 90% left main on this patient, and 70 to 80% left main on this patient. And interestingly, they do have their Framingham risk. This was a 49-year-old patient with a 7% Framingham risk, which is low risk, no ischemia on a stress test, and their calcium score is actually 0 on this patient with a 90% left main. And then the second patient with a left main disease, again, Framingham, 5%, 52-year-old female, no ischemia, calcium score 14, which is basically nothing. But both of these patients went on to have cabbage. And this was, 5% or so of the patients that were screened, whereas and more than 10% actually had revascularization. But these 2 are the patients that definitely, you feel like you did something prognostically relevant by by bypassing their left main, and you think that you're putting them at lower risk for future events. Our current, there's been reviews and these guidelines we talked about, but there's not a whole lot on coronary CT because there's just, like I said, not a whole lot of data. 45 patients, these type of small studies. But I will say that the data may be even more compelling than the perfusion data that I don't think is very impressive. So we've talked about detection. Now just to touch quickly on treatment of multivessel disease, status post-radiation. And I wanted to show this set of pictures because this is an angiogram of a patient just like ours that had a history of chest radiotherapy and concern with coronary disease and went on to have coronary angiography. And you can see this ostial left main. And really the rest of the vessels look fine. This is ostial left main, but the LAD looked good, circumflex looked good, the RCA looks totally normal. So this is a patient that, when we talk about risks of open heart surgery in these patients, that probably now with current angioplasty and stenting techniques, this is a patient that's ideal for just doing a left main stent. It's uncomplicated. We can have more complicated forms of disease. This is a patient with proximal LAD, bifurcation of the diagonal, and mid-LAD that I think traditionally, this would have been considered a lesion that would have gone to CABG, but now we can do bifurcation stenting and can get pretty good results. And I think this is one that in a patient with a history of chest radiotherapy, if the benefit risk wasn't great with open heart surgery, that you can make a good case for. But let me show our patient. So he's got a diffuse left main lesion, bifurcation disease, and a pre-existing stent from his STEMI. And they don't like really doing overlapping stents very much. So the surgeons in our case said, this is not a great, or the interventionalist rather said, this is not a great lesion, and is there anything else to consider? So for patients that have indications for CABG after chest radiation, there is a little bit of data, and here I just wanted to compare what's been reported for sort of all comers with CABG from the STS database to patients with coronary bypass grafting. And really it's just these two tables. On the left is it's all comers with CABG. On the right is patients with chest radiation and CABG. You can see that the 30-day mortality overall in patients with all comers is about 3%, and it's almost 9% in patients with radiation. Other complications such as prolonged ventilation, around 6% in all comers, close to 9%, so higher in patients. And these guys can have radiation pneumonitis and things like that may put them at risk for this. The sternal wound infection post chest radiation, again, is the concern in these people. In all comers, it's less than 1%. These guys are 10 times higher in patients with chest wall radiation. So other things that can be a problem post-radiation, this is a CT of the heart. You can see very calcified LVOT and proximal aorta. So for cross-clamping going on pump, this is definitely not ideal. Calcification of the mitral annulus, they have to, for open heart surgery, they have to put a vent through the mitral valve to vent the left ventricle, and they don't like to do that with a lot of calcium in there. These are some other, this is the normal pericardium and normal sort of chest anatomy, but these other pictures demonstrate some post-radiation changes. You can have thickened pericardium that adheres to the chest wall. Here again is very thickened pericardium. This can just be problematic for accessing the epicardial coronaries, especially if it's very calcified, such as this patient. So these are all post-radiation changes that can be problematic. And here's the porcelain aorta. And as you can imagine, if you were going to do traditional vein grafts, your aortocoronary conduit, the proximal anastomosis would be almost impossible to plug in here to this aorta that's totally calcified like a pipe. There are some bright spots in these patients, though. This is data showing that patients post-radiation, as long as their internal mammary is in good shape, that they tend to do better than vein grafts. At 10 years, there was a trend towards improvement, but you can see from 3 to 5 years that the mammary versus the vein graft, that the survival was much better. This is our patient's chest CT. His pericardium looked pretty normal. You can see his left internal mammary there actually looked good on the CT as well. The surgeons did say when they got in there that he did have some adhesion sort of superiorly in the chest, but that wasn't a problem given the fact that he had a mini thoracotomy and not a sternotomy, but it could have been problematic. So in terms of looking at this type of hybrid revascularization versus open conventional bypass surgery, a few things to touch on. This is in all comers. This is not in patients with a history of radiation, but I think that some interesting data can be gleaned from looking at this comparison. The all-cause mortality was essentially identical. However, the patients that had hybrid revascularization instead of the traditional open had much less incidence of prolonged ventilation. Almost a third of that in the traditional CABG group, and as we recall, patients with chest radiation history tend to be at increased risk for prolonged ventilation. Furthermore, excess site infection, so this would be the sternal wound infection or the thoracotomy. These guys, they had no access site infections in the hybrid group, whereas in the CABG group, they, a number of them did, although not high. But this would be reassuring in our patient that, is at higher risk. Also, reoperation for bleeding, primarily here, and chest tube drainage and need for blood transfusion was statistically lower in the hybrid group compared to CABG, as was their length of stay and recovery in the hospital. And this is just a sort of graphical schematic showing the same thing, that these guys, hybrid versus traditional revascularization, the overall major event rates are about the same, but they tended to do a little bit better with procedural complications and CABG-related bleeding. This is the Kaplan-Meier mortality curve up to 3 years out, and the guys that had hybrid revascularization had a non-statistically significant reduction in death from any cause. So I think that you can feel like you're at least not doing a disservice by doing a hybrid type of procedure, and that you may be addressing some of the morbidity related to CABG in these people. So that's it. Sorry I ran a little bit over. I'm happy to take any questions and comments. Anybody there?
Hi, Greg, it's Roger here from Canada. I'm an echocardiographer. Really enjoyed your talk. A couple quick questions. The exercise SPECT, I presume that you're going to call that a false negative based on the data that was provided later on, obviously, in the case. The place I did my echo fellowship was a pretty good nuclear center, and they had access to PET imaging. Do you guys have access to that in terms of doing coronary flow reserve? And then the second question I had was, in patients who had previous mediastinal radiation, do you happen to have like sort of multimodality cardiovascular rounds with the surgeons in terms of surgical planning? Because he was able to have an endoscopic procedure, but as you alluded to, there was obviously a risk of converting to a conventional sternotomy. Thanks.
So we do have PET here at our hospital here in Tampa. and that our clinic is affiliated with. However, the cameras are not sophisticated enough to do the flow reserve. They kind of get flooded by the tracer. So we can do PET, and the nice thing about it is attenuation correction and, that kind of stuff, that the specificity is improved, but the flow reserve improves sensitivity, and we don't have that. So we're still limited. We can look at TID and that type of thing that can help improve the sensitivity, but we don't currently have that. Although we do have a relationship with Lance Gould in Texas, who is one of the kind of PET gurus, and we have sent patients there if we want flow reserve. So we can get it done if we have patients that are willing to travel to Texas. In terms of the sort of multi-specialty rounds, the thing about the hybrid revascularization is it's not very widely done. It's not widely available. And there's nowhere that's close, it's not done here in Tampa. We actually sent our patient up to Emory, where I did my cardiology training. I was familiar with physicians there that do this. And they really up there make it a heart team approach, sort of like is done with other hybrid procedures, the structural heart disease and that type of stuff. So I was very comfortable knowing that the surgeons and the interventionalists work closely together up there and are all on the same page. So I think it's important, and it is one of the sort of prerequisites to having a program that does that type of operation. Yes.
Are there any further questions from anybody? We'd like to thank Greg for his very nice presentation. There's certainly at least 100 things you could talk about in this case. So this is a great case, and we appreciate you presenting this. We'd like to think that cardiac CT might play an increased role in patients with previous radiation exposure, given the limitations of SPECT scanning. So thank you so much, Greg. We recorded this for anybody who would like access to it. It will be put on the ACOSNA website, and so we appreciate your attendance, and it is available for you, for the other attendings and their fellows. Thank you so much for coming.